and really specific. A lot of times this SI joint can get overlooked in diagnosis and workup and some management of some of this chronic low back pain, or even some acute low back pain that can really slow people down or really affect their lives or their quality and their function. I am a physical medicine rehabilitation doctor, so my specialty or my board certification is in physiatry. So I'm really more of a head-to-toe approach to this stuff. I'm not a surgeon, but I work with a bunch of surgeons, so I kind of call myself this non-operative orthopedic doctor. My tools are basically the conservative approaches to this stuff, trying to really get a hold of whatever it is we're looking at. And again, I know we're talking about SI stuff today, but back pain can be a multitude of things. And really what I'm looking for is trying to find some balance there with keeping pain under control, keeping people up and moving and running, with really all those conservative measures. I've got nothing to disclose. I'm not getting paid by anybody. I've always years if anybody wants to fund anything for me. No, we're just required to do that stuff. So again, tonight, we're going to talk about just some low back pain, some general stuff with that. Really kind of focus more on the sacroiliac joint as one of these causes for it, and talk about some reasons for that potentially being an issue or a source of some pain for some patients, and why that might be, and also talking about what does that pain typically feel like, or how do people typically describe that pain when it does come up. Some things, again, how we diagnose this stuff, and then some treatment options, and not just conservative stuff that really I'm more on the side of, but also Dr. Aldridge, hopefully coming in here and talking about some of those surgical approaches and really some other interventions that could be done if I'm able to, let's say, help out, but if it's not enough and we can really diagnose this stuff. Dr. Aldridge has some tools in there that are more kind of permanent fixes. So low back pain, and this is probably not news to most of y'all. This is second to the common cold. This is the most oftentimes the reason why people are seeing their doctor in the first place. And so this is not something that's unique to anybody. We all wear our backs out as we get older, and it's always typically these lower lumbar segments, and again, that SI joint is, it's not within that lumbar spine, but it is attached. I mean, it is, and we've got some kind of cartoon models up here to kind of show you where this SI joint is specifically and how it relates to this kinetic chain, which is our body. Everything's connected, and so everything is part of that that chain of that reaction. So, needless to say, low back pain, there's a huge component of lost production, lost money, lost benefit, quality of life, function. All this stuff can really have a very huge impact on people's lives. So this is a cartoon or description really of the anatomy of the spine. In the upper spine here we have our neck, and this is what's attached to the base of our skull. And then you've got 27 vertebrae that run down the entire length of your spine, and these are all well supported with muscles on either side, anteriorly and posteriorly. But like I said, this is all connected. It's all a kinetic chain, and that's from your big toe joint all the way up into these joints that attach to the base of your skull. We've got some curvatures in our spine as well. And the reason for this is just this is the way that we've been built. That is most efficient for us to travel, for us to move. But over time, this stuff starts to break down and starts to wear out. Our thoracic spine is kind of more in the middle. This is more where these ribs are attached and kind of right around our chest. Our lumbar spine has 5 vertebrae in it. Our bottom one being this L5 vertebra, and that attaches directly into the sacrum. The sacrum is kind of a triangular shaped bone, and then you have your pelvis on either side of that sacrum, and in between that sacrum and ilium is your sacroiliac joint. And ilium is really just kind of some fancy words for the top part of this pelvis, or this ring in through here. And people forget that that is a joint. Just like our knees, our hips, our shoulders, it wears out too, and it can get arthritis in it as well. This didn't work last time. I don't expect it to work this time. This was supposed to show us directly in where this is. But if we were to overlook this skin, this sacroiliac joint is kind of right around this area. And what I'm looking for when I diagnose this stuff is, is your pain above your belt line, or is your pain below your belt line? And we're going to go into a couple more of these diagnostic approaches that will let that make sense. So the anatomy of this SI joint. This is a pretty complex area. You've got, in our body, to say the least, is extremely complex. But you've got this joint that is underneath all of this ligament and muscle support. And so this SI joint is actually underneath all this white stuff in through here along the midline of this spine. So just to orient you all here, this is the back of your back, and this is the midline of our spine, and then we're just seeing one half of this pelvis. And so this is actually the femur, or our leg bone. And then these are some muscles that are attaching through here. This SI joint runs right down this line and through here. And you've got all these ligaments that support this joint. And this joint is typically a very solid joint. It does not move very much. But as you can imagine, as we get older, these ligaments here get a little bit looser. And the way I like to describe that to patients is kind of like a rubber band effect. You take a rubber band and you stretch it long enough, it just gets a little lax. And especially for these, for the moms out there, when you have babies, and it doesn't matter in your 20s, 30s, 40s, and I know people have babies in the 50s now, you have a hormone that's released called relaxin, and it does exactly that. It relaxes this pelvis so that that baby can fit through that opening. Now, when we deliver and we have that baby, those ligaments, or all this pelvis, this has to tighten back up, but it's not like it was before you had that baby. And so oftentimes I see a lot of women in their 60s, 70s that have never had issue with their SI joint that start to at that time. And I ask them, are you a mom? Have you had babies? And it's usually a yes. And it doesn't matter if it's one baby or if it's 12 babies. This is still part of this. And of course, everybody is a little bit different with this as well. And how severe this is, or more benign, or how limiting or not limiting it can be, it's all across the board. The other thing I wanted to say about this is, you don't have nerve roots necessarily running through this joint, but you do have these nerve roots running around this joint. And even more importantly, this is not like a knee or a shoulder or a hip. You've got these other receptors in this joint that can really mimic a lot of other things in your back. This is a joint which can mimic a radiculopathy or a sciatica. Are y'all familiar with that as far as, pain going down the back of your leg, back of your thigh, sometimes even below your knee into your calf? It can also mimic groin pain, which is very pathognomonic typically for hip osteoarthritis. And so you've got this area back here where you've got your lumbar spine, which is a little bit higher in through here, this SI joint here, and this hip joint, all within about this area. And so oftentimes these can overlap and they can mimic each other, and it can be very challenging to diagnose this stuff. And that's not uncommon either. I get a lot of folks that have gone to several physicians, and and they've seen lots of people, and everybody's telling them a different thing. So you're not alone if you're frustrated with that too. The SI joint dysfunction, really the prevalence of this is 20 to 25% of low back pain is coming from this SI joint. And again, there is a lot of other structures and places to potentially get some trouble in our low back, but that is a really huge percentage of low back pain. And again, this is kind of we're kind of coming full circle around this SI joint. It was kind of lost in the mix for a while. You know what, this joint it's supposed to be solid. It shouldn't be bothering you. It should be sitting, sitting where it's supposed to be. And essentially it's not moving anyway. So why are we even, talking about it? But I find that, more often than not, it's putting some medicine into this joint and this home run. I mean, we are knocking this stuff out of the park, where people have had epidurals and they've had hips replaced and they've had back surgeries and they've had, all these other interventions potentially that it's not the right side or the right structure with this. And so this is, I think, a really important slide, because you've also got, patients that have had lumbar fusions. Now, when you fuse your spine, when Dr. Aldridge fuses your spine, not me, he's putting some scaffolding in there to stabilize these segments. And it's usually a disc pathology that comes with it. But when you're putting in screws and rods, you're still a kinetic chain. So everything, again, is still one piece. But you start fusing places, and that energy has to go somewhere. So that, let's say, for example, this L4-5, L5-S1 fusion that you get, well, you're putting now more wear and tear at that L3-4 level, that's just above it. And then you're also putting a little bit more stress or a little bit more wear and tear below that segment, which is the SI joint, that next movable segment down. And this is called adjacent level disease. And so we know this, up and down and through. This is something that pretty much everybody across the board that gets a lumbar fusion experiences at some point in time. And sometimes that means that fusion can get extended, or sometimes that means that this SI joint takes the brunt of a lot of this, and then we need some other interventions in there for it as well. Some common causes of this SI joint dysfunction, and again, we've talked about just a couple of these, but lumbar fusion is a very big one. I see a lot of folks that have had their lumbar fusion, and this could be, hey, they had their lumbar fusion back in the 90s, back in the 80s, or they just had it in 2015. At some point in time, you start getting, hey, it's achy, it's sharp, it's dull, it's sitting, it's not quite, it's my low back, but it's not my back. It just feels like it's my butt, or it's right around the top part of my, the dimples in the back of my bottom, or I'm getting this pain now in the sides and through here, or I'm getting it, in the groin. But my orthopedic doc has told me my hips look perfect. I mean, these are kind of these stories that I'm hearing that are coming up with this stuff. Obviously, any traumatic event is going to affect our musculoskeletal system. Pregnancy, we talked about. Just childbirth alone can be pretty traumatic for these SI joints. And this is why these obstetricians, these gynecologists, oftentimes will give these pregnant patients SI joint belts. And what all we're trying to do really with that is stabilize those joints, because we know they are lax in pregnant women. And they can irritate and give pregnant women and post-pregnancy a lot of trouble with it too. Just like with any lumbar pathology, falling, lifting, repetitive injuries, whether that's work-related or sports-related, what you did in your previous life is always carrying with you for the rest of your life too. So the basketball players, the football players, the rugby players, the gymnasts, the dancers. I mean, we see all these folks, and they are putting a lot of stress on their bodies, and sometimes you don't end up paying for that for many decades later. This is a picture of a study that was done looking at SI joint pain. And then you can see here, and this is kind of what I was talking about before with, this is not a black and white clinical picture for me. I get people that come in here and say, it's actually very little in my back. I get it all in this groin in through here. And then we put some medicine in that SI joint because I'm doing some of these other provocative maneuvers to test that. and then we turn off this groin pain. Or we get this pain that is going down all the way to the back of the leg, like a sciatica. And you don't have a nerve pinched in your back, and your core's not getting squeezed. We put medicine in this joint, and we turn that stuff off pretty well. And there's some other medicines that I like within this as well, as far as that nerve pain. And what I mean by nerve pain, burning, stinging, stabbing, tingly, pins and needles, electricity. That's a different type of pain than your, I broke a bone, I twisted my ankle, I got a cut. This is not really well treated with your anti-inflammatories, with narcotics. It really deserves a nerve pain medicine. So these dimples of Venus, I think is what we call them, at these low back, patients oftentimes point to these spots. And that, again, is kind of right just below that belt line or the top of the bottom. Of course, it can just be in the low back and centered in the low back. And that's why, again, we've got these other diagnostic tests to figure out. Because remember, we've got that small area. Is this hip joint? Is this SI? Is this coming from your lumbar spine? Or is this coming from a different structure? Again, the sciatica-like symptoms, or that, those lightning bolts going down the back of your leg, that doesn't have to be from a disc herniation. And again, these receptors in this joint are not like your typical your other joints. There is thermal receptors and mechanoreceptors and these other proprioceptive receptors that make this pain feel very different than, well, my knee has arthritis and I get pain in it. If my SI joint has arthritis, why does that feel the same? Because this is a much more complex structure in there. And it's a really funny joint. It's like a twisted boomerang. It's curved, but it's kind of tilted, and it can be very hard to diagnose just with imaging itself. Again, pelvis, buttock pain. I was in Denver for our annual conference a couple of weeks ago, and at a lecture actually on the SI joint. And a lot of these physicians are now trying to maybe categorize this stuff as posterior pelvic pain. There's a lot of pelvic disorders, and some of them don't even really want to throw it into kind of the lumbar side of things, because it's very different, and everybody describes that a little bit differently too. But that's for another day. And again, hip groin is pretty common with this as well. Buckling, giving way, and of course that could be a lot of different things as well. Hip pathology, knee pathology, not just SIs or low back. And that really is just your body's way of protecting you. Just like your body's way of telling you if you've got injury or if you've got instability or irritation is to give you pain, is to tell you that there's something going on here. And that's not always an easy marker for some of this stuff too, because again, pain is subjective and everybody is feeling this differently. This is a common picture of kind of sitting on a side. This right SI joint on this girl is hurting her. At least that's what we're going to pretend like the picture is for. And you can see her taking pressure off of that. At the same time, I get people that say, if I just drive my knuckles into this, it helps or it turns this stuff off. And you get people walking around with just like a tennis ball in their back or a lacrosse ball or something. But obviously it's fatigue standing, because that stuff starts to kind of put pressure on it or weight into it, and you've got to just stand. But standing or sit. And sitting's not comfortable either, because that starts to kind of tighten up also. And so you get these kind of this round the carousel thing of, hey, I can't stand, but I can't sit, and so I'm just gonna keep moving. And that can be exhausting as well. Difficulty sleeping, and again, that could be a lot of other stuff as well, but that tossing and turning is not uncommon as well, seeing some of this stuff. Or at least initially trying to get asleep, and then usually most people can find some sweet spot where they can fall asleep, but then they wake up because they're turning or twisting again too. I think we talked about that, some of that, going from pain, increasing, going from standing to sitting or sitting to standing. Stairs is pretty common with this as well, and it's not just going downstairs, it's really going upstairs. And that's just a mechanical stress on that SI joint when you're putting pressure through that area. So how do we diagnose the sacroiliac joint? Again, we're kind of rediscovering this as a really common cause for some low back pain for folks. And it's not usually part of that typical low back pain workup. Hey, let me get some x-rays. If that's not working, let me get an MRI. You don't typically see a lot of degenerative changes in this SI joint, or if you do, it's not diagnostic that this is where this pain is coming from. It is often misdiagnosed, and unfortunately, there's a lot of folks out there that are getting hips replaced and they're getting fusions in their back that don't need them. I'd like to think I'm trained to look for it, but yes, there are other doctors out there that are not, or it's misguided. Because it can be really that great masquerader, you know. Is this coming from your back, your pelvis, your hip, your disc herniation and sciatica, you know, and everybody's kind of banging their head against a wall, including your physician, trying to figure this stuff out sometimes. The way I like to diagnose this joint pain is putting a needle into it. Can I put some medicine in there and turn this stuff off, or really turn it down? And really that has been really a gold standard for me, because otherwise it's hard to say, hey, this is exactly where this pain is coming from, unless we can kind of get in there and try to turn that light switch off. Some diagnostic criteria we use for this SI joint. The first one is Fortin sign, and that is really just with your finger. Hey, I hurt here. That can be diagnostic itself, but we also need more than just, you know, patients saying, I hurt in this area. So we do some distraction, we do some palpation, we try to do some of these maneuvers and try to load this joint and see if this is reproducing patient's typical pain. And again, number 3 here is really this either diagnostic and therapeutic, or diagnostic or therapeutic injections into this SI joint. And I use x-ray guidance to make sure that obviously needles are going where we want them to. We're not just blindly putting needles into your butt or your low back and hoping we're in the right spot. We do need that imaging to make sure that we're going to the right area. So this is that Fortin's finger test, and this is just, hey, where do you hurt? And usually people are pointing to around those dimples, kind of right below that belt line. So kind of an easy way to divide this stuff is, you know, is this pain coming above L5 or is it coming below L5? And L5 is typically kind of around that belt line. You know, the tops of your pelvis, if you feel your pelvis here, that's typically about L4-5 level. And below that, I start thinking about more of this sacroiliac joint.
We had a question. Do y'all numb that spot first?
Of course. So we numb the skin over that area. I want to say I'm fairly good at these, and so this procedure is very painless. It's pretty similar, or even sometimes less than, you know, just putting some medicine into your knee joint. You know, and then you just do that right there in the office. I have a fluoroscope or that image guidance all within our office, and so it's not that we got to go to the hospitals and we got to get, you know, all the other kind of craziness that can come with that too. This is right here in my office. But yes, of course, we numb the skin up with some lidocaine before we put that spinal needle in there. And this is usually already a tender area, and so you are feeling some pressure as it's going through some muscle and through some of this connective tissue. But usually if we can get that needle into the right place, it's more numbing medicine, and then usually a little steroid we put in there too. And that's just to hopefully have that effect or that benefit last. And really what I'm going for with that is maybe 60 to 100% better or pain relief, and 3 to 6 months would be a pretty good response for these medicine. Your body's going to metabolize any medicine we put into it, and of course everybody's going to be different with this stuff. Sometimes I do these injections and I'll see people 2 years later, hey, it just came back. It's been gone 100% for that long. And some people say, that was not even, that wasn't even a drop in the bucket. It helped for about an hour and then things were coming back. So it's not uncommon that we get a wide array of results with this stuff. But again, I'm not going to be doing this stuff for you if I don't feel like it's going to benefit you, and I don't do anything for anybody if I wouldn't do it to myself or to my family.
This sounds similar to the ablation.
So, no.
Okay.
Yes and no. We have the ability to do radiofrequency ablation to some of these sacral segments that come off of these spinal nerves in our back, which could take away some of that sensory innervation to that joint, and then hopefully take away that pain for many months. That's kind of the idea of that ablation, is that you're burning these sensory nerves, and any of these nerves in our body are going to grow back. But we can lesion them, and they grow back at about maybe a little bit less than a millimeter a day. And so oftentimes we can give patients 6 months up to maybe a year and sometimes more relief with that. The problem is that everybody's innervation is a little differently. So the nerves I can get to with that radiofrequency, sometimes it's a big component of that joint innervation, and sometimes you've got a lot of other nerves that I can't access that are still innervating that joint. And again, that's where you kind of see these differences of, hey, it helped a bunch, or it helped, but it didn't really help all that much. Again, these are those provocative tests that I'll be doing for these patients to try to diagnose some of this stuff too. And some of them overlap, but we're really just trying to load that joint and see if we're reproducing some of this similar pain that patients are having. Some of these are pretty awkward to get into, and I don't do them. I try to keep it pretty simple and relatively easy for the patient, because you feel like a pig on a spin if you're like doing circles on the exam table of me rolling you around. But usually this is a pretty easy diagnostic tool, and we want to get a few of these in here to really kind of hone in on, hey, this is our diagnosis, or if we do an injection for this stuff, we're looking for a lot of benefit. As far as that SI joint injection, I've talked about it a little bit through here, but I really feel like this is going to rule in or out this SI joint as being your pain generator. I do use fluoroscopy or X-ray guidance to make sure that needle's going where I want to, and then we put a little contrast in there as well to make sure we are in the right spot, or that when I do push that medicine in there, we're going to be in the right spots that I want it to. If I'm in a blood vessel, that's going to give you zero benefit. So I've got to make sure that we're in that structure, in that joint. And then diagnostic purposes, and this is maybe a little bit more on the academic side of things. If I'm there and I'm in that joint, I don't want to just put a little lidocaine in there and turn this off for an hour. That you're going to say great, and it was right back. If I'm there, I want to put a little steroid in it as well, as long as, in addition to some Marcaine or some lidocaine, some long-acting anesthetic. I do believe that power of kind of turning off the light switch, or turning off these pain receptors and letting your body kind of reset some of it as well. And then, again, that steroid, hopefully just letting this stuff last, that anti-inflammatory effect of that steroid really helping this last for many months.
We had another question. What if you've already been diagnosed with ankylosing spondylitis? Do these injections help?
Yes, they can help. Typically with ankylosing spondylitis, that process usually starts in the SI joints. And these are patients that their spine is really kind of fusing up itself. It gets really stiff. And so these SI joints, if they aren't moving, or if they're moving too much, again, this is that kinetic chain. It's all kind of connected, and that energy's got to go somewhere. So yes, that can help out. But there's another component on top of that, being the ankylosing spondylitis. That's a rheumatological condition that you need other medicines in there to control that immune response, similar to a rheumatoid arthritis or a lupus or something else too. But that is specific to the spine, typically, and to the SI joints. The SI joint injection, this is, again, part of more that diagnostic side of things where more in these academic centers, they'll just put a little numbing medicine in there, have you do some maneuvers or some tests to kind of to see if, hey, are we turning this stuff off or not? I feel like if you're coming to me, it's my duty to make sure you're not having to come to me every, really frequently. So I want to be able to do something that's not just diagnostic, but also very therapeutic. These are some other non-surgical techniques or some other conservative measures to manage this stuff. We do have pain medications. I'm a less is more kind of guy. I really don't, I don't push narcotics at all. I actually would really try to prefer people to stay away from them because they just give you another problem. But there is a place there that we do need pain medicines sometimes for this stuff too. Anti-inflammatories are very good medicines for this as well, just like with any shoulder pathology, hip pathology, knee pathology. I mean, we get arthritis everywhere, and this is a joint just the same as those other ones as well. Some patients can't take anti-inflammatories. Tylenol is still a good pain medicine. People forget. It's not a good arthritis medicine, but it's still a good pain medicine. Sometimes patients can be limited, and we can really optimize some of those other things. Ice is always a good medicine. Heat is always a good medicine. Sometimes just changing your position can be good medicines with this stuff as well. Chiropractic, sometimes some manual manipulation can help out with some of these troubles as well. Usually they're relatively temporary, but again, that's more on my side of things. Everything I do is temporary. But a lot of times patients can find a lot of really great relief with chiropractic care and even some sustained relief with chiropractic care too. Physical therapy I'm always a fan of because it puts it into your lap. Hey, these are the tools, these are our stretches, these are the exercises, these are the things that you have control of because everything else in your back and your spine you don't have control of. The muscles are really all you've got to really kind of dial this stuff in. And that is for the rest of your life. You've got control of these muscles. And I always want to feel like patients have that empowerment of, hey, you're controlling this, it isn't controlling you. That SI belt we talked about a little bit too. It's not just for pregnant patients though. The trouble with it is that it can be a little bulky or a little cumbersome. I mean, it really just sits across the pelvis and through the hips and through here. But that can stabilize that joint really well. And then steroid injections, and then the radiofrequency we have talked about, that we can burn some of these sensory nerves that are innervating this joint and give patients some pretty good relief. And before we burn any nerves, we're doing a diagnostic test, which we are putting some just numbing medicine in these areas where these nerves are to see if we can turn this stuff off. And if we can turn it off really well, maybe more than 50% better than what it was previously, or your normal back pain or butt pain, then we can burn those. And that is all in all a pretty safe process. And there's no steroids being used with this stuff too. This is that SI joint belt, and you can see how that could be a little bit cumbersome or maybe a little bit more uncomfortable. And yes, this is not really well tolerated. But some patients, they're not wearing this during the day and during work and throughout the day. But at the end of the day, they put it on. I mean, it's something that in the comfort of their home, and it gives them just even a percentage of some relief. That's better than nothing. And so this is a good, easy thing to do with some of this as well. Physical therapy, again, we're trying to provide those tools that can keep this stuff relatively under control, or as much as control that we can have with it too. And that's just not your body mechanics and gait and balance and strengthening your core and your lumbar spine, but also giving these muscles some guidance or some training. Your muscles, and I tell patients, are kind of dumb. They're just there to support and stabilize, and they're sensing either injury or irritation, and they're Their flip is to just, their switch is to just tighten down. They're stabilizing. But sometimes they don't get that message to back off. And so we can get a lot of tenderness, sensitivity, muscle spasms that can come with this as well. And at the very least, I like this very bottom one here, this cardiovascular conditioning. It doesn't matter what orthopedic or musculoskeletal conditions we have, pain doesn't kill anybody. Heart attacks do, strokes do. So we've got to have these patients have some of this control so that they can get their heart rate up a few times a week, at the very least. These orthopedic type of conditions are really what couch people and put people in bed, and then they're not moving because it hurts to move. So we've got to hopefully diagnose this stuff correctly, give the proper medications, and then let patients move. I mean, that is really what it's all about, because if you're not moving, everything else is going to start hurting. Again, we talked about this. I'm going to kind of jump through that. It's just that therapeutic injection, really just using. This is that radiofrequency ablation, and you can see these. The idea here is these branches from these sacral nerve roots that are innervating this joint. And we really are only able to get to the ones that are on that surface of that sacrum, but you have other nerves that are innervating that joint as well that we don't have access to. But if majority of those nerves from those sacral branches are innervating that joint, this could turn this pain off really well for a while. And this wouldn't be something that I would jump into first. First, it's, hey, let's just try to put some medicine in there. Let's diagnose this correctly. And if that is the case, and let's say it helps out a bunch, but doesn't last very long, this would be a very reasonable approach. And again, nothing I'm doing is changing the anatomy. We're not stabilizing this joint. We're not moving anything. That's when Dr. Aldridge kind of comes into the picture, and he's starting to change some of those mechanics. Speak of the devil. Oh, you want to talk about your part too?
Sure. Hi, I'm Dr. Aldridge. How are you doing? How doing? So, you're all in pain? Well, this is the man you should see first. So, normally when people come to my office, a lot of people had a lot of treatment. A lot of people may have had a lot of different diagnoses. And sometimes it's the wrong diagnosis. So, you really want someone who's kind of good at looking at all the different parts. And that's what's unique about our office, especially my office. I do hips, knees, spine, a whole bunch of different body parts. So when you come to my office, I'm used to looking at your hip, at your spine, at your SI joint, and trying to figure out which of those 3 or 4 parts may be the problem that's causing the pain you're having. Some people, it's everything. Some people have a bad back, have a bad hip, and a bad SI joint, and end up with a replacement of the hip, spine fusion, and the treatment of their SI joint too. But it's very important to figure out which part is the real problem, which one's hurting you worse. As you can see from the diagrams before, all the nerves come in and they kind of crisscross, get in your spinal canal, then they go up to your brain, and your brain tries to decipher that. And the same nerve roots innervate lots of different spots. And so that's why I have patients come in all the time who've had back surgery or have been told they need back surgery and they really have a bad hip, and vice versa. So the most important thing I would tell you to get out of this lecture is go to a doctor who can diagnose or treats each body part so you get the right diagnosis. Second thing is to make sure that you try everything first before you go to surgery. So Dr. Bradley is very good at keeping people away from me, which I'm very happy about, because if he can give you a shot or a little treatment and you feel great, that's much better than surgery with all the recovery time and everything else that could go wrong with surgery. So once you have the proper diagnosis, once you've tried everything, then it's time to talk about surgery. The last thing to think about surgery is surgery doesn't fix everybody. Now, how many people have had back surgery in the room? How many made it better? Made it better? How many made it all better?
One of them.
But you're still in pain.
No, I had 2 surgeries. One made it all better.
Was that the first or second?
That was the first circle.
Okay.
The lumbar.
Yeah. So bad surgery gets a lot of bad press because, a lot of times it doesn't work, and it may not work because it may not be the right spot for the problem. The other thing is when you fuse something, it can cause problems in other parts of your spine. So I'm sure Scott, Dr. Bradley put up a slide that said about 35 to 40% of people after they have a back fusion end up with sacroiliac joint problems. If you go to a surgeon who only does back fusions and doesn't treat the sacroiliac joint, you may get your back part fixed, but they may just kind of say, well, there's nothing more to do for the sacroiliac joint because they don't know what to do about it or they don't know how to diagnose it. Because it's not something that people routinely do or have done in the past. Because in the past, there really wasn't much treatment for it in terms of a surgery. The surgeries we used to do, you had to go in through the pelvis, through the front, and move all the intestines away and put a plate on the inside, or we had to basically strip your butt muscle off the backside and put a plate and screws in through the backside. Either way, the surgery did much more damage and created much more problems than the actual SI joint problem in the first place. So up until about maybe 7, 8 years ago, before these devices were designed, we just kind of didn't do that because it made people worse. Very smart guy who developed some other spine solutions for older people with compression fractures, came up with these little implants to take care of the SI joint through a little like 1 to 2 inch incision. In my hands, it takes about a half an hour. You kind of put these things in through little percutaneous holes over guide wires under a live X-ray machine with a live neural monitoring to make sure we don't get near any of your nerves to stabilize that joint. Obviously, when you have a bad SI joint, it's either moving too much or it's arthritic. Either way, stabilizing that joint should take the pain away if you have the right diagnosis. Things like the physical therapy, the SI joint belt, stretching, all those things are designed to try and take the stress off the SI joint or stabilize it and make it more stable. If those things don't work, then this is the right solution. Like I said, it's been pretty good. I think I've done about 200 of them. And I think out of 200 people, probably 180, 190 people are very satisfied. 1 or 2 people were not satisfied. And I think part of that's because they weren't honest about what kind of relief they got from the injections. And when you do those diagnostic injections, if you tell me that made all your pain go away, that makes me think that that's the problem. If it didn't really, and you just think this operation is going to fix all your back problems, then you're not really being honest with you, not being honest with me, and you're not going to be happy with the operation. Because if you don't pinpoint the problem, you're not going to fix the problem. Does this video work?
I think so.
Okay. So the implant that we use is a porous titanium. It's the same implant that we use for hip and knee implants that we've been using for 30, 40 years, so it's time tested. It's got a triangular shape so that it resists rotation. Because in the slides before, the motion on that joint, even though it's very small, is a rotation type of motion. So a circular implant would still allow rotation. The triangular one reduces that ability to rotate. So here's the outcomes. If you look at patient satisfaction, they're all in the 90 percentile. Kind of goes along with my numbers too. Done about 200, I'd say about 180, 190 are satisfied with that. And not only are people satisfied initially, the satisfaction stays with them. The satisfaction and pain scores drop significantly and are maintained over the first 5 years that we studied. So it not only gives you good relief initially, it also gives you relief long term. And this, out of all the implants that are out there, this is the one that has that data on their patients. Some of the other implants don't have the same data or don't study it. They're kind of using this information to kind of push their implant. This one's been studied very well. So as I said, they enrolled a bunch of patients, 148. They randomized them. They followed them for up to 2 years. NSM is non-surgical management, which means Dr. Bradley, exactly this stuff. And the iFuse, you can see the scores dropped in terms of pain level way down, and it was maintained for 2 years, for 12 months on this study, and 94% satisfaction. All of this goes into, though, having the right diagnosis and on the right problem. If you're putting this into the wrong patient, you're not going to be satisfied. You see, patients who failed the non-surgical management, as soon as he did the iFuse, the pain scores pretty much dropped, equivalent to people who had the iFuse from the get-go, and they maintained it for that first year. Of the patients that didn't cross over, their pain continued to get worse. So my talk is very short because usually Dr. Bradway spends a lot of time with you trying to keep you out of the OR. You come to me, we have the right diagnosis, worked as a team. You're one of the unlucky people who have failed the conservative treatment, and then we move on to surgery.
Can I ask a question?
Yes, ma'am.
When you were talking about causes or some of the reasons why a person might develop this, how about leg length differences or scoliosis where the hip is out of kilter? Is that a common cause?
Yes, I think so, and there's there's going to be kind of varying degrees of that depending on how big is that leg length discrepancy, how bad is that scoliosis, and not everybody with leg length discrepancy has SI joint pain. You could have a perfectly level pelvis with SI joint pain also, but yes, that's not uncommon.
Another problem with scoliosis, you're out of balance, so
Right.
you have edge loading of the spine. So as you get older, parts wear out faster than if they were straight up and down. That stiffens the spine up, and if the spine is real stiff, it's going to act as a big lever arm on your sacroiliac joint. So it is increased risk for SI joint problems.
Okay, so you said you've been doing it for 7 years. So is this a permanent fix?
If you have the right diagnosis, and we've had patients who maintain that relief for 5 years now on the studies. So yes, permanent fix for the SI joint. Doesn't mean you can't get other problems.
Well, does it cause other problems? Like with the fusion, it can cause the SI joint. Does this surgery cause another problem?
Typically not, because the motion here is so small. You're talking 1 or 2 millimeters. So the next joint over would be your hip, which is very mobile. So it doesn't really add more stress there. And then going up your lumbar spine, it's only eliminating 1 to 2 millimeters, where your lumbar spine has a lot more motion and degrees of freedom. Where when you fuse that, it really affects the level above and below.
Okay, so are there any restrictions on physical exercise? Like can you play golf?
Close.
I encourage you.
You can? Okay. Okay, where do I sign up?
I want everybody to play. That's why I practice medicine. My last thing I want is for patients to feel like they can't move, or you're stuck in a chair. I want you doing everything that you can do. I mean, we're here for quality of life, right? It's we only have one life, so let's make sure it's a good one. And especially in our later years, this isn't. Golden years, they're a little more rusty than golden. And I don't want folks that are retiring and they've been gearing up for that their whole life, and now they are suddenly stuck. They're not moving, or they hurt when they move. And again, some of that behavioral, the modification with this is that your behaviors are going to dictate what you can do and what you do. If it hurts when you get up and do something, you're not going to do it. And so we're trying to keep bodies in motion, because we know that's how we're built. We're supposed to be in motion. And so I'll do anything for you that will not hurt you, that will keep you in motion.
So what's the recovery time?
Usually about 4 to 6 weeks.
4 to 6 weeks?
Yeah. Most people, it's either outpatient or next day. Like they have it done, ready to go that night or the next morning. You'll have some soreness, black and blue in the buttock region. And once that soreness kind of goes away, about 4 to 6 weeks, most people feel good. Your pain kind of transitions, though. Instead of the SI joint pain, you're having this sort of pain from the surgery and the bleeding and the bruising on the hip area.
Yes, sir.
Dr. Bradley, the SI injection, what did you use to guide it?
So we have an X-ray guidance. It's called a C-arm. So it's kind of a portable X-ray that looks like a big C. I do thousands of these, so I have lead on, to protect myself. But it's really not any more radiation than probably a flight cross country.
And if a doctor does it without that, what's the chances of actually hitting?
Very low. You can use ultrasound or CT, but you need some sort of guidance. But freehand is very...
Yeah, and if there's no guidance there, it's probably just going into your muscle, to your butt muscle, which is going to be, yes, it might help out for a really short period of time, but it's not going to last. And more importantly, it's not going to diagnose anything for us. It just might give you a little relief.
The other issue is the dye. Dr. Bradley uses a little dye, and that, even with the needle, sometimes you're not really in the joint. You don't know it until you put that little bit of dye in there. Or CT scan, which is a very, very magnified X-ray.
Does the surgery require general anesthesia?
It does. I mean, we can do it in our spinal, but most of the anesthesiologists, because you're face down, they want to have the control over your airway. But it's about, like I said, about 20, 30 minutes of general anesthetic, which is very quick. But we could do it in our spinal, but like I said, the anesthesiologist, they don't want you to stop breathing, and then they're trying to intubate you upside down, which is very hard for them to do. Yes, ma'am.
Is the steroid that you use to diagnose, is it similar at all to cortisone shot?
Yes, ma'am.
That's basically what it is. So are there long-term concerns with doing that?
So we try to limit really any steroid injections, whether we're talking about SI joints or knees or hips or backs. We try to limit this stuff to maybe about three a year. And that within the medical literature, there's not a hard and fast number. Hey, 3 is fine and 4 is too many. We do know that the less we do of these, the better they work. The more pain you're in, the better they work. The more we do of them, the more your body kind of gets adjusted to that stuff. And it's not uncommon to hear folks, hey, I had an epidural or I had this injection, and it helped for 2 years. And then you come back, and the next one helps for a year. And then the next one helps only for 3 months. And then the next one only helps for a couple of weeks. I mean, that is, we do see some of that. And so the other really important reason for that is your body produces its own steroid. If we're giving you steroid too frequently, your adrenal glands that produce some of that steroid kind of kick back because they've already got plenty of it. When that steroid has already been run through, meaning the steroid I'm giving you, your adrenals have to kick back in, and if they haven't been turned back on in a long time, that's something called adrenal insufficiency, and that can end you in the hospital. So it's really my job to make sure that I'm not putting you at risk of any of that stuff. And yes, sometimes we stack these up, and that's okay too, just knowing that, hey, we want to limit this stuff. And I kind of talk about a 12-month kind of cycle. You know, how many steroid injections have you had over the past 12 months? And like I said, it's not that it's off the table if you've already had 3 of them. But if you come in and you say, well, this doc did a trigger point here, and I got a burst injection over here, and then my shoulders bother me, and I got an injection there, and then my knee, and then I've had 6. Well, I'll probably say, let's try some other things here so that we're not putting you at more risk. Because also, it just might not help. Your body really might be adjusted to those steroids, and then it doesn't matter what area we're putting them into. But yes, that's my job to make sure I'm not putting patients at risk of that adrenal insufficiency or getting them into trouble. That's a good question.
Can I ask a question? I'm a physical trainer, and I'm just wondering, you mentioned physical therapy and chiropractic treatment as possibly helping, but can hip strengthening, back strengthening, all those things, if they're done, can it eradicate it? I mean,
yes.
It's mobile, like you say.
I think so. I mean, every patient's a little bit different, but I sometimes send patients to therapy, and they're 100% better. It cures it. I mean, it's gone. They don't need injections. They don't need other medicines. I mean, they just needed a little bit of some guidance or a little bit of some training for those muscles. And these are usually patients that they're diligent. Hey, I went to therapy and I did the homework and I'm still doing it. And I went back to the therapist and I modified this because that wasn't helping, or I couldn't tolerate that. And I mean, they're really involved, and all of you should be advocates for your own health. Nobody else is going to. And yes, you need good doctors in your corner to advocate with some of that too, but most people kind of fall off the wagon. Hey, therapy helped, and I did it, and then I stopped. And then everything comes crashing back down. So yes, sometimes we can cure this stuff with just what you're doing. And again, that's really my approach of this kind of that conservative management to try to keep this stuff under control. Because regardless if then we go on to do a shot or if you're going on to do surgery, I still need you doing that stuff. This is maintenance. I mean, this is stuff for the rest of your life. You've got to stay on track with that, or else things just start to kind of crumble. And that's what all of our bodies do as these years are going by. It's our bodies are built to kind of fall apart, and unfortunately, we're all living till we're 120 now. So, I don't think our bodies are really much more built for more than probably 70 or 75 years or so. Things just start kind of domino effecting. Sometimes less than that. But. Any other questions? Is there anything?
Okay, well, thank you all for coming this evening. If you would like to